Hello guys. Today I'm going to be talking about what happens in the CAT test of the ALS course, because this is something that you only get to know on the day of the exam. So I wanted to give you an insight of what is going to happen in the practical test. So basically you are going to be given a scenario such as this. I have written it down. I came up with it on my own. So uh, it could be very it could not be very technical. Anyways, so I had one of the scenarios in my exam similar to this one. You can see a 50-year-old having with the background of COPD admitted for acute exacerbation in the hospital, and he's suddenly feeling very unwell. So the nurse on duty has called you to have a look at him. So they are going to give you some details. Some other relevant details might be there, that he might be having a chest infection for which he is given an antibiotics and fluids and some other details, and they are going to repeat it back to them, so they know that you understand the scenario very well. So for example, this scenario comes in your exam. So how are you going to be proceeding with it? So you have a mannequin placed in front of you, and first of all, we are going to be applying A to E approach. So let's start with the Airway. Introduce yourself. My name is Dr. Ibrahim, one of doctors in the emergency department. Confirm his identity. If he's able to speak, then that's great, which will mean that his airway is patent and you are happy with the A. And if he's not able to talk to you, he's mumbling or he's not responding at all, then we have to check the GCS. So we are going to be giving him some pain. How can we inflict some pain? We can grab his trapezius and squeeze it to give some pain. Sometimes you can, with the help of your thumb, you can put some pressure on the sternum, and it also inflicts some pain. And if the patient is responding to the pain, then we can grade his GCS. So if he's not responding to the pain or he's just mumbling, then we have to secure the airway. So in ALS, they expect you to know how to secure an airway. So you have to put the oropharyngeal airway in the beginning. They will teach you how to do it. So just place it. You have to insert it actually in the mouth. So there is a specific way to put it. Anyway, you secure the airway, or if the patient is talk to you and you say that the GCS is more than 8 and the airway is patent, then you proceed with the B. So in the B, we are going to be checking his. So first of all, we are going to ask them to um, place the probe into the finger so we can know what is the oxygen saturations. And for that, we are going to ask for help. I would like to call for help on the bed this, because the patient is feeling unwell. So one person is going to come for help, and they are going to be grabbing the equipment from the crash trolley, and you are going to be using them. So SpO2, you are going to be checking. You are going to be listening to their chest sounds, as this one is COPD. I'm going to be writing down. So first airway, and if compromised, we are going to be giving oropharyngeal airway, right? And in the B, we are listening to the chest sounds. We are checking the SpO2. We are checking if the trachea is central. I'm not going to be writing every single thing down because it is going to take a lot of time. Okay, so in the breathing, you are checking trachea, you are checking bilateral expansion, you are checking the chest sounds, you are tapping, percussion, and yeah. So in this scenario, most likely we are going to be having some crepitations because he is having acute exacerbation, which means there is this chest infection. And SpO2 should be less than 94%. In usually the COPD patient, we are going to be keeping the saturation between 88 to 92. So we do not need to give a lot of oxygen in that one. So we are going to ask them if they have COPD or not. So let's suppose the oxygen saturation is 80, then obviously we are going to be giving them oxygen. You are just going to be verbalizing it, and in COPD you are going to be giving it with the Venturi mask. Let's start with the 24%, and we will increase it if needed. So B is done. Order chest X-ray and blood EBGs, that is also a part of B. And then we move to the C. We are going to be passing cannulas. We are going to be giving them fluid if the blood pressure is low. We are checking the capillary refill time. C is done. Some investigation you are going to order, such as inflammatory markers, coagulation profile, D dimer. Now we move to the D part, checking bilateral pupils. We are checking the temperature. We are assessing GCS again, and which is an ABPU system, in which we check the alertness, the consciousness, the pupil reaction, and if the patient is able to respond to the voice. So according to that, we are going to grade his consciousness. And then we are going to check the blood glucose. Then the E part, in which we are going to be checking for any bleeding, any rashes, bruises, and then deformity. Okay. So what happens in the exam is that when you are close to the D part or the E part, they are going to suddenly say that, doctor, the patient has collapsed. Is the either the monitor is not reading any pulses, any no heartbeat, or there is patient is not able to breathe now. Previously it was breathing and there was a blood pressure or something like that. So he has become vitally unstable suddenly. So what we are going to do, we are going to immediately be checking his pulse. So let me open this scenario. So we are done with the A to E. The next part of the test is this algorithm that we have to follow. So immediately check if he's breathing, if he has pulse. He doesn't have any pulse. Immediately start CPR. Okay, you have started the CPR, and you have called for the help immediately. And we are, as soon as the help is going to be arriving, you are going to be asking them to take over for the CPR. For example, I'm doing the pushes 1, 2, 3. So I'm going to be counting it backward, like 5, 4, 3, 2, 1, and immediately after 1, the person is going to take over you, and they are going to be doing the CPR. And what is your role now? You are going to be the team leader. You are going to be asking the other people to either shock the patient, either give them drugs such as adrenaline, and insert the airway if it is needed. So these are going to be things that are going to be told by you, and they are going to be scoring you on that. So let's suppose we ask the people to attach the defibrillator. We have asked them to give the oxygen via the bag mask ventilation. And what is your role now? So we are going to be assessing the rhythm first of all. Defib is attached. For example, it is VT or VF, which is ventricular fibrillation. Then it is a shockable rhythm. If it is pulsus, electrical activity, or asystole, then obviously you are not going to be shocking them. So just follow the this algorithm. So if it is a non-shockable rhythm, then you are going to be just giving them adrenaline every 3 to 5 minutes. Okay, which means that in the first cycle you are going to give them the adrenaline, and in the next you are going to skip it, and then in the third one you are going to give the adrenaline shot. It is going to be given IV, and it is going to be 1 milligram, 1 in 1000. Okay, so basically every alternate cycle. And in the meantime, what you are going to be doing is you are going to be going through all the 4 H's and the 4 T's to find out the reversible cause of the cardiac arrest. Okay, so let me zoom it in. For example, a cycle is going on and they are telling you that, yeah, we are giving this, and in the meantime team leader is ordering them to do things for him, and also is going through 4 H's and 4 T's. So physically you are not doing anything, but mentally you are doing everything. Okay. So let's talk about this scenario in which the patient was admitted with a COPD and his oxygen levels were less. So first of all, first H is hypoxia, very likely. That is the main cause of the cardiac arrest in this patient, because the patient was his oxygen levels were very low. So we are going to be reversing it. How we are going to be reversing it? We are giving them oxygen via the bag mask, and as soon as we are comfortable, we are going to be inserting the Giddel airway, which is a supraglottic device, um, also known as eye gel. So we just put it inside the mouth and then we give them the oxygen. Okay, so the blood pressure was most likely normal, so hypovolemia is not the cause. There is no bleeding. Usually the hypovolemia is the cause if there is a bleeding or diarrhea or vomiting that lead to the loss of a lot of water, and so we are going to say that hypovolemia is very unlikely. And then hyperkalemia is then again very unlikely. Why? Because the ECG is okay. Okay, I forgot about it, but in the C part you are also going to be looking at the ECG as well. And also we have other ABGs in which the potassium levels are given, so we can check, ask them to check for potassium levels in the ABGs. And for hypo and hypothermia, just ask the patient who is doing the CPR to check for the temperature of the body if it is okay. And hypo or hypothermia are usually in the settings where the patient was outside the hospital, not inside the hospital. So either he's in the stuck somewhere in the very harsh weather environment, such as in the very snowy area, or is working too hard in the hot climate. Then we are thinking about hypo or hypothermia. Uh, Also happens in the drowning cases in which there is hypothermia. Then we are talking about thrombosis. The first T, again very unlikely. There is no history of cardiac problems, so no coronary or pulmonary problems. The patient was not there, doesn't have any risk factors for any pulmonary embolism as well. So now skipping it, the tension pneumothorax, we are going to ask for bilateral entry of the airway in the both the lungs. So pneumothorax is going to be ruled out as well. And also when we are checking the trachea to be central, we can see if there is tension pneumothorax or not. Tamponade, again, it is due to the trauma. There is no history of any trauma to the chest. So, and there is distension of the JVP veins and hypotension. All these things again absent. For toxin, we can ask them to check for any drugs that the patient is taking, such as morphine, benzodiazepine, because these are the most common cause of patient going into cardiac arrest, or insulin as well. So if you go through all these H's and T's and address them, then it is very unlikely that you are going to be failing this exam. So now let's come to the last point. Even though we know we have to do these things, that still we keep on forgetting them, right? So I wrote down the mistakes that I used to make. So silly mistake, one of the silly mistakes that you forget to ask for help, and they are not going to be coming to you for your help, and when you are not able to have the probe for the oxygen saturation, because you are checking the patient, you can go to the drawer to grab it. Then you realize, oh, I forgot to call for help. So immediately as you see that the patient is sick, call for help, so you have a helper in hand. They are not going to obviously fail you if you're not able to call for help, but it is something that lowers your confidence if you forget about it. And yeah, one more thing is that if you are going to be checking for pulse, for example, the patient is in PEA, and you see that there is a sinus rhythm, you cannot say it's sinus without checking the pulse. But you have to ask the people who are doing the CPR to stop the CPR, then check the pulse, because the CPR is going to be generating its own pulse as well. So you might get a false pulse check if the CPR is going on. So that is another mistake. that a lot of people make. And okay, so the mistakes they are going to be failing you on, these are the, if you do not go through the S's and the T's, if you skip any of the H's. For example, in one of the cases, the patient was having asthma and he went into a pneumothorax, and they were trying to tell me that he's having a pneumothorax by saying that they are not able to push the air into the lungs. They are trying to, squeeze the mask, but it is not going in. So I should have asked them to listen for bilateral entry of trachea to be central. So one of the T's I missed, and they are not going to pass you on that. Rhythm check to be done at the end of the cycle. So in the middle of the cycle, if you feel like the patient might be recovering, do not ask them to stop the CPR. Allow the 2 minutes to pass, after which we are going to be assessing the rhythm. So we want minimal interruption in the CPR to make it more efficient and effective. So do not ask them to stop in the middle. So that is another mistake. Okay, another mistake, it is very obvious, but we do make it. It is that we check for the pulse. We do not check for the pulse before declaring that it is pulseless electrical activity. So we do not know if it is pulseless without checking the pulse, right? If you see a sinus rhythm and patient is unresponsive, you have to check if there is a pulse or not. You cannot say either it is a sinus rhythm or it is a pulseless electrical activity without checking the pulse. It is very obvious, but we do make mistake. Okay, don't forget your all team members. So what happens in the exam is that they do not have 4 or 5 people for your help. Actually, there are 2 people or 3 people. So what happens is that we sometimes forget about the airway, sometimes we forget about the IV cannulation, sometimes we forget about the defibrillation. So just keep in your mind this, you have to visualize these people in your mind. You have to imagine them, even they are not there. Just ask them to do these things. Okay. So one is for the airway, one is for the defib, one is for the cannulation, one is for the CPR. These are very essential. So in one of the scenarios, I forgot about the airway because there were only 2 or 3 people. So there's another reminder that if the patient is unconscious or is not talking to you properly, check the GCS immediately. As I told you, that just give him some pain and to see how is he responding, and then insert the OPA. So these were some of the mistakes, and I think if you go through all these things that I told you, and you do not make those mistakes that I made, you are going to pass it easily. So best of luck for your ALS. It is easy exam, but due to the high pressure environment, you tend to forget things and you make silly mistakes. And I think if you go through this video before going to the exam, you are going to be feeling very confident. Thank you for watching.